Hello, and thanks for joining us on this live panel discussion as we are talking about whooping cough, which has kind of gotten a lot of attention in the headlines here in northern Michigan over the past several weeks. I'm Bill Freilich from WTCM Radio, and I am joined by Wendy Truth, the health officer at the Grand Traverse County Health Department. Wendy, thank you for coming in. Nice to have you. And Dr. Matthew Jackson from the Creekside Clinic. Thank you as well for stopping by.
Thanks for having me.
So we want to just kind of cast a wide net here for folks, and we are also taking your live phone calls. This program will be rebroadcast again at a later date, but here we are on Tuesday the 25th of November taking your phone calls live, and we will be putting the phone number there on the screen for you at several points throughout the course of the evening. But the phone number for you, 929-3696, if you've got a question about the topic we're discussing, which is whooping cough, of course. I want to start out just kind of broad range, Wendy, if we could, in terms of how this started. Obviously, it started somewhere, but it really got attention at one of our local schools, and that really is kind of where it snowballed in effect, right?
Yep. Well, it always starts somewhere. You're right. And at any given time, there's cases in our community. But in this case, we ended up having a few confirmed cases in a very short time frame, within a day or two. And when we talked with the school, and this was the Grand Traverse Academy, they had a lot more people who were symptomatic as well. And as we began to have that kind of discussion with their administrators, it was clear that they were heading probably towards an outbreak. So that's kind of how it all started.
Mm-hmm. And they shut down for 4 days a couple weeks back to try to basically stop the spread, right?
Well, they shut down. It was not a public health action. It was a school decision to shut down. Mm-hmm. They had a very high absenteeism rate on a Monday and decided that it was probably in the best interest of everybody to shut down for a week, allow families to get the prophylaxis the health department had recommended, and that's the antibiotics.
Right.
And try and get people to stay at home and not get more people sick.
A lot of folks in the community, school community and otherwise, respond with concern. So there's some anger out there. Lots of questions get tossed around. But again, even though this school, started at that school, it also started somewhere else. It came from somewhere.
Yeah, there's pertussis that circulates, throughout the nation, actually. There's outbreaks that happen, and, part of it is a disease that is vaccine preventable, but I will also say that the vaccine is not 100%, and it doesn't give you lifelong immunity. So as the vaccine kind of wears off in certain age ranges, and as people travel to other places where pertussis might be more common, then you're going to see cases that happen.
Got a dozen questions to feed off of those comments, so I want to, we'll try to kind of go down the list here and get through some of those. But in terms of the vaccine itself, and both at this school and some of the others that have been affected, are there student cases? Are there students who came down with pertussis, with whooping cough, that had already been vaccinated?
Yes. Yeah, we actually expected to have, roughly, I think, 30%. The vaccine effectiveness is about 70%. And what that means is for 7 out of 10 people who are vaccinated, they would be fully protected from getting pertussis. And then the other 3, it correlates to a much milder form of whooping cough or pertussis. So we did expect that we would see some cases in people who were vaccinated.
And we did.
We did.
It's not entirely... obviously, it's not unheard of that kids who have been vaccinated will get whooping cough. And I also know, we talked about this round of antibiotics for both staff and students at that school, if not others. What is the motivation for that, even for kids who have already had the vaccine?
Well, the point of the antibiotics that we call it prophylaxis, is to prevent them from getting sick if they've been exposed. So if we know that there was many people in the school who were confirmed cases, and I think we're at 12 in that school, and they were symptomatic, then based upon how they interact, and we look at that too, how much close contact they have. So the concern was making sure that it really didn't, that we stopped it. We didn't get more confirmed cases. We're still at about 137 probable cases. Some of those we've been able to eliminate. We were at 167 because tests came back negative, but there were still people who were symptomatic. They were coughing. There was a lot of coughing going around.
In the county or in the school?
That was in that one school.
Okay. Do you know, it doesn't have to be exact, but ballpark what we're looking at in the county or in the region for confirmed and probable cases?
Well, the community cases, which are ones that aren't linked back to that school, we're tracking the confirmed, and we're at, I believe, 36 overall, so about 24 in the community. There are some in neighboring counties. It's kind of starting to be spread throughout northern Michigan. And the probables are usually affiliated with an outbreak, and the community cases aren't considered outbreak cases. They're kind of the normal background cases.
Okay.
And I think the doctor can probably talk to how busy their office is, but those cases, the probables are more ones that we're just monitoring or who are being tested. We're waiting for test results back. Well, we really don't have a total number on community probables.
Okay. I'll come back to you, but we got to give you a chance to breathe, and we'll talk to Dr. Jackson here again with the Creekside Clinic. How busy have you been? What kind of response did you get from families in terms of after this outbreak and after it started to spread to some of the surrounding schools?
We got pretty busy. Initially started off, we got the communication from the health department that's saying, there's been an outbreak with confirmed cases. And the recommendation was to start, if you have an exposure, to prophylactically treat them with or without symptoms. And so we, once that was posted, we got pretty good amount of phone calls initially that first week with families asking to be prophylactically treated. And we took the line of actually just when they asked for it to be prophylactic because treated, we allowed them to get those antibiotics with the phone call and a conversation with our on-call nursing staff that works with us. And there was two reasons for that. One was to treat the family. Even if they hadn't been fully up to date on all vaccines or if they've all been vaccinated to the guidelines, we still allowed them to get those vaccines. But also, from a broader standpoint, to help try to contain that outbreak from getting into the more at-risk population, which is your younger infants, and kids under six months of age or younger. And for me, even hit home a little bit more personally, having a 1-month-old at home who hasn't had her vaccinations quite yet and is at a significantly high risk. We know that the mortality rate for young infants going through those initial series of immunizations is pretty high when you get exposed to pertussis and become infected.
Pretty frightening, yeah.
So there's the immediate family members that we were trying to protect, but also more broader socially, the infants in the community that haven't had their full round of vaccines or even haven't had any significant vaccines at all related to pertussis. That was our secondary reason for just allowing patients to get their antibiotics as directed by the health department.
I know that your clinic, Creekside Clinic, had a different approach than another place in town. We don't have to necessarily mention names if you don't want to, but different offices handled it differently. Not every office was in favor of prescribing those antibiotics, especially without symptoms. But that was part of the goal, was even if you don't have symptoms, we want you to take that booster or that antibiotic, right, Wendy?
Yeah, I mean, there's clear CDC guidelines for outbreak situations. And, normally I think physicians practice medicine, they're not practicing under an outbreak condition. And sometimes the recommendations medically for an outbreak situation are different than they would be day to day. And so that could be part of it. Some of it is, there was 1,200 plus families flooding the system all at once looking for prophylaxis. So that's a lot. That's part of why we set up the hotline for these families. We've handled over 1,400 phone calls. Some are callbacks, but we've probably facilitated over 1,000, 1,100 doses of prophylaxis for people who were considered exposed.
The other part of that question, I guess, that I want to get into is just the nature of the antibiotics. Again, that round of prophylactic was even for kids who weren't symptomatic. And there is, as there is with the crowd that is against vaccines, there is also just the general concern of are we giving too many antibiotics for things that we don't have? I've got no proof of pertussis. Why am I putting more medicine into my kids? How do you respond to those parent questions or concerns?
It's a very good question, and a lot of how we handled it was, one, we had a little bit more detailed conversation with the families. I think for us it was that anyone requesting the antibiotics, we definitely just allowed them to have the antibiotics. And the questions come up is, okay, if you are worried about taking the antibiotic, and is it truly a reason for me to, without any symptoms, I don't have any immediate confirmed cases, then the question can be asked, well, is there anyone in your immediate family or area that you might have a high risk, such as an infant, for example? And that would be the next, if there's nobody, all my kids are 18, I'm willing to sort of not let them go out into the community as much around more high-risk population. Then the conversation, well, let's maybe talk about doing the culture to find out if we necessarily need to treat you or not. It becomes a more case-by-case question and answer with the individual patient and family based on those types of questions. Obviously, you're not going to be able to force anyone to do anything, including immunizations or take an antibiotic. And it's sort of just informing them as much as you can and coming with the patient and the discussion with the family to decide, what would be the best course. And a lot of times, well, I'm not around any immediate high-risk population. The exposure was sort of not really in sort of the classroom that I was in per se, and those more detailed, nuanced parts about the exposure can be kind of worked with case by case in the individual physician's offices or providers' offices, and then a decision can be made based on that, whether or not to go along with it's a recommendation to prophylactically treat. It's not like you have to be on an antibiotic just because the entire school has been exposed. So that once you get sort of the next ring where it's more nuanced, I think then you start getting into like more of the clinical decision making that's responsible to the individual providers to decide, okay, we've had this conversation, I think it is reasonable for us to wait on that antibiotic. So not every single person that's called in asking gets it. Those questions they usually come in for an office visit, and then it's a discussion face to face. You get a better sense of how concerned they are if there's really a truly good immediate exposure. And then you get more detailed, what's your cousin, you have cousins, family, anyone with small children that potentially could be extremely impacted by this, and then that's when you can either figure it out, yeah, we're going to take the antibiotic. The antibiotic itself has generally been around for a long time, and we do know sort of how it interacts in dose-based dosing and with the patient, so it's a relatively safe medicine to take. The risks versus the benefits are always weighed, and then you just decide with the patients.
Yeah.
Could I add a couple things?
Please do.
Okay. First, I should say that testing is important. I mean, it's important to know what you're dealing with, but when you're in an outbreak setting, like we were with the one school, there becomes a point where it's not feasible to test everybody. Feasible even from the standpoint of the primary care, they may not have enough tests or they might not be able to. And second, it takes up to 10 days to get the lab results back on some of these. By then, how many people have been exposed because we haven't started the prophylaxis? So that's part of, in an outbreak setting, why you start that prophylaxis. And certainly in public health, we are not just about throwing antibiotics at people. We understand the risks of too many people having antibiotics as well. But with something like pertussis, which by the way is called the 100-day cough, it's a serious disease that can be very violent. It's not just about that individual, it's about protecting those that they're around. It's about protecting the infants, protecting someone who might be on chemo, who has no immune system right now. It's more than just an individual decision. And we have had cases of people who didn't initially get the prophylaxis and then became a case. So
Here recently.
Yes. Yep, we've had a few circumstances of that. So just because someone isn't at that point in time showing symptoms doesn't mean that they can't then become ill, and by then they've exposed other people. So there is science behind it, and there is a reason that it's recommended and that we do it.
You've got this 2-week dormancy period, maybe? I don't know if that's a fair word, but 2 weeks where you can be without symptoms but still carrying pertussis. And I was going to ask, this all happened, 3 to 4 weeks ago, if things are dying down now, if the pace of the reports is dying down, but simultaneously, if you can incubate for 2 weeks, we potentially still have weeks and weeks ahead,
It seems to be slowing down. It seems to be slowing down. And a lot of the new cases don't have any link back to that particular outbreak. So what we might be seeing now is just our new community norm. And because that outbreak brought that diagnosis to people's minds, maybe people weren't thinking about it. It hadn't been, we hadn't seen many cases in recent years, maybe 5 max in a year, that now parents are aware of it, teachers are aware of it, more physicians are aware of it, and so now people are probably getting tested more, so we're going to see more cases.
What about the extent of the family unit, moms, dads? My kid goes to that school, or they've got pertussis in their classroom. Not only getting my kid vaccinated, but should I be on antibiotics? Will my kid bring it home? Any of those things for adults in the family.
Yeah, I mean, that's part of the prophylactic recommendation for the antibiotic. And then there is a question for the adults: have they received their one immunization that they're supposed to be getting for the booster, which is capital T DAP, which is the AP is a pertussis part of your tetanus shot when you get it at your doctor's office. You're right. It's recommended that you get one of those boosters as an adult, with the 5 immunizations that you're supposed to get as a child before age 6, and then you get one more. You get one more in there with a little change to the TDAP at age 11. And so the question is, did you get your booster shot? Yes or no? I'm not sure. Probably good idea to check with your provider and just confirm or deny that. If you've gotten it, then the question is, the recommendation still is a prophylactic treatment for an exposure. That's a secondary exposure from the school. It becomes much more tough to sort of answer those questions if they're if the individual patients are resistant to taking an antibiotic. I mean, and the treatment for pertussis has been historically azithromycin or the macrolide class of antibiotics, and that hasn't borne out to be having, with the outbreaks that we've had historically around the nation, kind of cycles on a 3 to 5 year period, depending on what information you read. Resistance hasn't really, at this point in time, given a good amount of time being treated with that one antibiotic, hasn't really borne out to become high rates of resistance to that particular antibiotic. So the answer usually is this is the recommendation based on CDC.
What if you've got a child who's 11 or 12 and just hasn't gotten that booster yet, or they're getting their booster shot next month? Do you do the prophylactic, the antibiotic, and then turn around in 3 weeks and do the booster? Should you just get the booster now and bump it up a few months?
Right now, with what we're seeing, I would say you do both. The mean age of all of our cases is 10. It's kind of the age at which we know the vaccine starts to wane when it gets closer to that 10 or starts to lose effectiveness around that 10, 11-year age group, and that's why they recommend a booster at 11 or 12. So given what we're seeing, it's really important. I would do both.
Because the antibiotic is just that. It's an antibiotic. It's not what you're injecting in the form of the vaccine. They're two completely separate. It's not as if you're doubling up on the vaccine.
Right, and just getting the vaccine isn't treatment for if you've been exposed. It's definitely recommended to prevent you from getting it in the future, but it is not the same as taking the antibiotics if you've been exposed.
You talked about the schedule for young people, but what about for adults? The tetanus, the Tdap, is that an every 10 years for adults, and is there a maximum age? Somebody had asked earlier today, got a 65-year-old person who was basically told, no, you're too old for it. But what if they're interacting with, some of the grandkids who go to the school?
Right. The guideline recommendation is that they have gotten one Tdap in their 10 years really is on the tetanus part of where that comes out of is the tetanus is combined with that pertussis vaccine through the immunizations as you go through them into adulthood. And there is a recommendation that you get one Tdap booster in your tetanus series. So at some point you should be, instead of getting the TD, which is a tetanus with diphtheria booster shot, that's the one that people think of when they step on a nail. A rusty nail is what people commonly associate that with. At every 10-year cycle, one of those should have been substituted to get a Tdap, which is acellular pertussis part of that booster. And I've had a hard time finding any sort of concrete data that would prohibit me from giving it to anybody that's any age really. And if 65, there's usually some grandkids associated with that family unit. And I would say yes, you definitely you should get that immunization.
So for this person
protecting your grandkids, not really you.
Yeah. There is actually a recommendation for 65 plus, you get a dose.
Exactly.
So I was going to say then, for this person who basically got told, no, you're too old, get a second opinion.
You can come to the health department.
I would say go to the health department. You should probably get you should probably get that immunization as a pertussis booster, that's included with the tetanus. Yes.
We call it cocooning. So he's got an infant who's 1 month old, and so anybody who's around that infant, if they're siblings, if they're grandparents, whoever the caretakers are, we recommend that all of them get Tdap as well as influenza this time of year, so that they're protecting the baby who can't get immunized yet. His baby's too young to get immunized, so you want everybody who's in contact with that baby. It's kind of like a safety net, and that's why we promote the immunizations as a whole too, because it is a safety net for the community. And if we had a immunization rate of overall of 90% or higher, that's what you hear it called herd immunity, or I call it community immunity. That protects communities typically from seeing outbreaks or large outbreaks too. So it is important.
Yeah, my kids got the antibiotic, and I was kind of bracing myself for this sticker shock. Like, all right, what are we up for? It's what, $5 or $6. I mean, it wasn't. Obviously, that will be an effect for some families, but it wasn't, $20 or $30 a head either to get this antibiotic. It shouldn't have
been an issue. We actually had a couple of pharmacies that the health department won't turn people away, or in an outbreak setting, we make sure that people who are recommended to get it. And so we have accounts at a couple of the pharmacies, and we referred people who didn't have insurance, who couldn't afford it, to make sure that they got it. But that was not going to be a barrier.
Good. We've just got a few minutes left, and we'll throw the phone number up on the screen again here in a second. If you want to join in the conversation, or if you have a specific question for something that we haven't covered yet, you can call that number on your screen, 231-929-3696. We are live here on Tuesday night, the 25th of November, talking with Wendy Trout from the Health Department and Dr. Matthew Jackson from Creekside Clinic about this whooping cough outbreak. We've talked about the antibiotic, we've talked about the vaccine. One question that came up about the vaccine, and again, from some of the folks who are concerned about vaccines, any side effects, anything that's more common than anything else in terms of, okay, if I give my child this, what might I expect?
They're really, as with all immunizations, anytime you kind of break the skin with any sort of needle, you can get a local reaction. And other than that, there's very rare instances where you can have an abnormal anaphylactic reaction to an immunization, but that's true with sort of anything, tremendous amount of things that you're exposed to in the environment in general. And you never really know that until you actually have had that exposure, whether that be an immunization or is something food related, or just something from the grocery store, like a cream that you put on for any number of reasons. So the reactions are very small and few between, and they're very rare. And then the actual immunization itself is only particles of that bacteria. So they're only pieces of the bacteria that are not sort of in any shape or form related to the actual bacteria in terms of being able to infect anybody. It is simply signals to your body to sort of make antibodies to that particular protein, and then when it sees that protein attached to a bacteria like pertussis, it should mount some kind of response to it. So there's no risk of any kind of infection from the immunization itself. And then getting into the more popular culture part of the immunization, it's not ever really been one of the immunizations that was really ever lumped into this, broader discussion of do they cause certain diseases in kids based on immunizations, at least from what I've read and from the literature that I've read. So that's out of all those, it's usually the more benign, immunization that we talk about with our patients.
Well, I'm sure there are cases of kids who've gotten sick who have not been immunized, families who have chosen not to immunize. And you and I had talked a few weeks back when this all started on the radio about how there was maybe a higher proportion at this school than quote-unquote average of non-immunized children. But again, I think it's worth repeating that even some of the kids getting sick were immunized. How do you juggle all that and try to figure out what numbers have been protected and does it matter?
Well, it matters. Definitely it matters. We did actually have our regional epidemiologist run some analysis earlier this week, and he ran it with just the outbreak at the academy. And what he found is a relative risk determined that kids who were not vaccinated were 5 times or more likely to get pertussis than those who were not. That's a pretty compelling figure to me.
Wow.
And if you look at the vaccination and the concern, well, what if you fall in that 30% where you don't develop the immune response? You do develop to some level because it is protective and that you get a milder form. But think of it as if there was a shot out there that could prevent us adults from getting a heart attack, and 7 out of 10 of us who got the shot, and then the other 3 out of 10, it made it a milder heart attack. For me, it would still be worth it. I mean, pertussis is a pretty violent disease, and if anybody's seen a little one with it, it's tough. They can stop breathing, they can throw up, they're coughing so hard, and it's just fits of coughing that they just can't catch their breath. So,
something that struck me as interesting, and I've covered these types of stories in the news for years, and either I've never heard it before or just never registered. We talked with TCAPS a few days later after they had a few cases in one of their schools, and they said that their, I guess, quote unquote compliance rate, if I'm using the right word, was 90% or whatever. They met the state guideline when it came to parents who get vaccinated. However, that doesn't mean that 90% were vaccinated. That just meant that they either were vaccinated or filled out a waiver that said we're not getting vaccinated.
Right. If you want to look at overall waiver rates, so waivers is those who choose not to get vaccinated, whether it's religious or medical, and the state of Michigan allows for a philosophical. We're one of the few states that allows for philosophical, and so we have a higher waiver rate than most states do. And so the overall waiver rate in the nation is 1.8%. In Michigan, I believe it's 6.3%. In Grand Traverse County, it's 11%. Really? There are some schools in our county that go as high as 30%. And maybe it doesn't sound like a big difference, but those differences are what contribute to the overall kind of that herd immunity number, and it is protective. I mean, it's like having a big net, and the higher the number of people who get immunized, it means the holes in the net are that much smaller, and so less is getting through.
Do you know offhand, and I'm sorry for putting you on the spot, TCAPS versus Grand Traverse Academy in terms of that philosophical or religious, or what the reasons are, or just generally the numbers? I mean, how does the academy compare to TCAPS, for example?
I'm trying to think of the numbers off the top of my head.
I know they're different because we had said that the academy was higher than
I think the overall waiver rate at the academy was 18%, and I honestly am not remembering what the overall TCAPS rate was, but I know it was lower than 18. I think it was probably close to the average.
Okay, but you said 30% was.
There is a school in our county that has as high as 30%. I don't know the name of it off the top of my head, but
okay, so it's out there. People should be aware that, if not you or your kid, could be somebody else's kid in the same building or in the same classroom.
There's some schools that have a better percentage too.
Yeah, It's true.
Yeah, and I want to really kind of point out too given that discussion is it's the problem too is that particularly with whooping cough, it's those kids in those schools can pick up that sickness, but then it's the broader, more at-risk population that then becomes seriously can cause them high mortality rates. So it's that secondary level too that people have to sort of consider when they're thinking about not immunizing their children, is it does impact you as a family unit, but then you have to sort of consider the other families that are in the area that have smaller kids that haven't got immunized that are going to immunize, and you can it's a social thing to also consider, to just say, is this something that I really want to sort of not go for, given the evidence and the sort of long-standing history of their effectiveness, and it allows us to sort of protect the more at-risk populations that we have in our communities by immunizing, in following sort of the guidelines from the CDC from an immunization schedule. So something to always consider. I think sometimes it's a little bit lost because you're worried about, everyone worries about their family.
Sure.
But then it's also that, there are friends and families that have little ones, that your people's friends that have maybe newborns and stuff like that, that I just ask people to kind of take that pause and really look at it and say, is this something that I'm willing to sort of not do, and then put the little ones at risk for whooping cough, which is a very serious, very, very serious illness if they pick that up at under a year and 6 months, and it gets exponentially increasing danger as they get younger and younger.
Is it fair to say, and I guess a question for either of you, that when you have an outbreak like this within the community, I mean, yeah, it may be isolated to one school, but those families are going to the grocery store. Those families are going to church. Those families have grandparents or parents who go off to work somewhere else. Is it unreasonable to say it's not a bad idea for everyone to get a round of antibiotics? Or if you've got, I mean, I don't want to make a public health scare, but
I think I would sort of stop short.
Yeah,
there,
that's a little unreasonable.
Or if you've got someone who works with kids, or a grandparent who watches the 7, 8, and 10-year-olds pretty frequently. I mean, what kinds of people should pay more attention than others?
They still have to have an exposure.
Yeah, I would say that's a great question, because it does start to get into, okay, how far do you go with this type of thing?
That's kind of what I wanted to get to.
That's where you start to say, at a certain point, that we still try to follow as best we can sort of the data that we have, the literature, the sort of what's been done, in the past with outbreaks. And I would say, pretty emphatically, no, you would not want to just say the entire Grand Traverse County. I mean, I know that's not what you were saying, but you want to talk then more the fine detail in terms of how close was that exposure from that grandparent who just say, is coming into town for Thanksgiving, right? So how close is that exposure to that individual child? If that boy or girl has confirmed pertussis, then probably that grandparent might want to consider getting a prophylactic treatment of that. That's something that would be discussed.
I mean, it really is. We come down to case by case.
It becomes down to case. That's where you get to that. I always kind of think of these things as sort of immediate exposure, classroom, schools, prophylactic for and then you start, as you get farther and farther away, then it becomes more a case by case discussion and personal preferences too. I mean, that you start really backing down on saying, no, I can reassure you that actually you probably are okay not getting that antibiotic. So
yeah, in public health every day we do case investigations when we have communicable diseases. Pertussis is one of them. So much of what our public health nurses do, specifically with these community pertussis cases, is they're doing the contact investigation, finding out, just like he said, how who their contacts are, what their risk is, how much close contact they're having, and making the recommendations from there. Since you mentioned Thanksgiving, which one of you mentioned Thanksgiving?
That was his fault.
Okay, so it's fine, but it's important to note that if somebody is being treated as a confirmed case and they have not completed their 5-day course, they shouldn't be around others at Thanksgiving, probably not what everybody wants to hear, but I think the doctor would back me on that recommendation that we don't want it to spread further. So
Yeah. Hopefully we're
Yeah, you have
through
to,
the
you
5
have to
days.
consider it. It's real. It's there. It's kind of one of those things that if just the questions, I would really just direct you to your health department, but also your provider. I mean, that's where you kind of want to lean on the medical community a little bit more. Maybe some questions like that can be sort of comfortably discussed with your healthcare provider, and your treatment decisions can be made more case by case once you're kind of more into that sort of outer realm of exposures for this particular outbreak. I think that's really where you want to get into having a good conversation, and just knowing that this is something that's real. It happens to be close to a holiday, but I don't think pertussis cares about that really. So
Yeah.
it's one of those things where it's just as something to just kind of get answered, and then kind of enjoy your holiday as well. So
a lot of people haven't seen the disease. They don't, because it was at a very low level because vaccines were effective. And so there's some of the diseases that I think the Record Eagle posted something yesterday about 100 years ago. They do that. What was going on? The health department was in there twice dealing with smallpox in the community 100 years ago. That's what we were dealing with. We don't see smallpox now, at least not in our country typically. So, but there are communicable diseases that it used to be common dinner time conversation about, this house down the road, oh, they have yellow fever or they have diphtheria, and that doesn't happen anymore because vaccines are effective. So part of it, I think, is people just don't even realize how dangerous these diseases can be.
On that note, I want to maybe just end with, we can wrap up with what people should look out for. What symptoms, again, if you're without symptoms for 2 weeks, people are just curious, like, what does this look like? If you haven't ever seen it before, you've heard the TV or radio commercials with the terrible sounding cough.
yes,
Yeah.
We've played that a couple times here lately, but what should you be on the lookout for, and when is the time to call the doctor?
So usually I say the problem with pertussis is it does present as, oh, this is like your runny nose, I don't feel too bad. And commonly we tell our patients, a lot of times in our training too, is after 7 to 10 days is not really, anything before that you're not really kind of too worried about any kind of bacterial infection, to be honest. It's usually mostly viral. The whooping cough comes into consideration when that sort of turns into a more persistent cough after about a week to 2 week time frame, and that cough becomes comes and goes. It'll be cough, 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 cough. The person either, if they're older, they don't really get that sort of whooping type of sound, and where they're really trying to take in a deep breath. They just will cough, 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 and then sort of just have to rest. They look a little tired because they get a series of coughs in a row. The kids, and I've heard it on the radio, and I've also, you can Google whooping cough, what it sounds like, and it's kind of one of those things, once you've heard of, same thing with the croup, which is a virus, is once you've heard certain types of coughs, you know exactly what it is. It's sometimes, then if there's any kind of question, I've told my patients even, I'm kind of got my training with the new technologies here. You can get your phone out, record your kid coughing, and bring it into me, and you can see that's a whooping cough. I mean, these microphones and watching them cough, it's like, yeah, that's pretty consistent with a whooping cough. So, that's kind of the biggest part of it. And the coughing in between those bouts, the child looks like they're pretty fine. I mean, they don't really seem to be bothered by it. They don't usually run a fever. And anytime they cough, 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 and then get a lot of any vomiting that happens after that, we call it a post-tussive vomiting, which after you've coughed a lot, you vomit. Children will get that a lot, and it occurs much more consistently with a whooping pertussis infection. And that's usually in that 1 to 2 week time frame. And then that type of cough is usually, especially given the outbreak we have, that's a time when you're calling your provider to find out, what do I do with this? And a lot of our training, anytime you've gotten any kind of cough past 7 to 10 days, is generally an actual medical indication for a round of antibiotics for a lot of these types of illnesses. So it becomes a less of a, it's easier to treat these once you've gotten in that conversation and talk with a doctor about those particular symptoms. But I invite patients to, if they're not sure, record your kid with the symptoms. A lot of times it's all the classic, oh, he's not coughing today in the doctor's office. It's hard to tell what kind of coffee he's having.
It's a great idea.
But you show me a video of it, and I'm like, I mean, that's pretty consistent. Like, you can't really fight that sort of sound that the child makes when they have that whooping type of
I'm going to take that
coughs.
trick with me for the auto mechanic too.
Yeah, exactly.
It's not making that noise now.
Just don't do it while you're driving.
That's right. That's right. Wendy, anything else to add to that list, and just in terms of what to look out for, when to know whether we should be concerned?
I think he covered it very well, and I would think the only other would be people who are at high risk, so infants, pregnant women, someone who is immunocompromised. If any sign, I think, that they're starting, they would need to talk to their doctor right away. Because that's a real big concern.
I would echo that as well. Yeah, any younger child like that, given the community outbreak, I would say recommend calling your providers sooner rather than later with kids that are sort of in the early immunization stage. They're just younger. They just are more at risk for any type of illness, really. But the whooping cough particularly can really cause them a lot of trouble.
Last question, and I know this is out of order, but I have to ask because we're still sitting here. For those of us like me, who I couldn't tell you the last time I had a tetanus or Tdap shot was. And I've had the same doctor for 12 years, so it's probably easy enough for me to find out. But for those of us who have had 5 doctors in 10 years, do you just go ahead and do it?
I actually say routinely, this is a low-risk immunization. The tetanus booster combination, the tetanus part of it in itself is a recommendation just to get it. And if you can't remember, usually we're recommending just get the shot, because most of the time people's memories are pretty good. And I know that, but a lot of times you'll still remember, I got that one shot way back when, right?
We'll remember the tetanus shot.
If you can't remember, I would say, just go ahead and get the immunization with the acellular pertussis included in that tetanus booster that you usually routinely get.
There is a registry in Michigan for immunizations that physician offices, health departments, anybody who gives immunizations does provide information into that. I think it tends to be a lot better for kids, but it's improving with adults. So it's worth asking your provider if it's in there.
All right.
Yeah.
We'll take it from there.
Okay.
Guys, thanks so much for being with us on this program, and thanks everyone for tuning in to Up North TV, channel 189 here. And I want to thank Wendy Trout from the Health Department and Dr. Matthew Jackson from Creekside Clinic.
Thank you.
For staying a little over and giving us all the insight. Thanks for tuning in. I'm Bill Freilich from WTCM Radio. Have a great evening.